Colleagues, good afternoon once again, and we are very glad to. I think we are ready to start, and we once again apologies for the delay, for the few minutes that we've delayed in starting. But we are very glad to meet you again, all of us who are managed to join the webinar. And I think at this point in time, as we are planning for our grants and we are reviewing the mechanism for implementing the grants, there is a very pertinent and very important topic that we've been discussing at country level, at organization level, which is integration. And we want to provide this opportunity today, this afternoon, to look at what that means for communities. How can we have provide an opportunity for us to meet together and discuss the fears that coming from the communities, the institutional arrangement that we are supposed to follow to ensure that at least we are integrating services, and why in terms of the overall purpose for integration. So this is a very wonderful opportunity. We are very glad that at least we can be able to meet and discuss. And I think most of us have or are already in the process of designing our country programs. And we have a new focus this time where we need to scale up integration of services, HIV, TB, malaria, and even the systems issues that we normally have to ensure that at least we have integration reflected across our country programs. So once again, I would like to welcome you on board. Thank you so much for making time to join. As we start the program, I want to confirm if my colleague Lisa can hear me. Am I audible enough? So at least we can continue. Or anyone or any colleague who is online.
Hi, John. Yes, you are audible.
Thank you. Thank you, Lisa. Thank you. So, as I've mentioned, the theme of this meeting today is for us to touch base on the very pertinent topic that is integration, and it's an opportunity like that we normally have from the Learning Hub to provide this space for communities to come together, engage, discuss, and just air the experiences from the ground, grassroots level, country level, and provide an opportunity for us to share more experiences and information on any pertinent topic. And for us today, we are talking about the integration. The main objective of this session, as I think I've mentioned, but just to put it as a recap, is to have this opportunity for us to look at what is happening, because we have been talking about integration for some time, which is okay. Some other countries have already started integration, especially after coming out of COVID. Some countries moved towards integration, and I think some of the affected components of our programming is really HIV and TB. Malaria has been part of the primary health care for a longer time, so at least for them it has not been very new. So we have started experiencing this. So we have this opportunity today to be able to come and see, yes, we've been talking about integration. So what has happened? What is happening, and what are some of the trends in terms of right from the policy perspective up to action and practice perspective. Then we also need to also take some time also within this meeting to also look at the implications. What does it mean? What are the implication of integration in our service as we provide? And I think that is where most of us are currently talking about with the lack of clarity, and also we are also being very careful to protect some of the programs that we've been designing and implementing over time to ensure that the integration process doesn't disrupt, or we don't lose the gains and the impact and the benefits of integration that we've managed to get over time. So we will also look at the role. What is the role? What is our role as communities, civil society organizations, CBOs, in shaping the integration agenda, and how do we contribute? Because at this level, I think we've all accepted that's the direction, that at a strategic direction that we're moving at country level, at regional level, even within from the international initiatives like the Global Fund, we've seen the WHO. All these initiatives are pushing towards integration. We have also integrated somehow to some level. So we are already into the system, and we are already prepared to do that. But the question is, what is our role? So we need to, are we able to put it more in a way that we can discuss and see what is the role of communities, civil society organizations, CBOs in the integration agenda, and have very specific and agree on what do we need to do as communities to make it happen. Because integration and in service delivery, I think we've all realized that without the voice of the communities, without the action of the communities, in most policy directions like these ones, it's very difficult to implement. Then we can also end up with having recommendations on how to move ahead, and see how we can strengthen where we've already started and there are bottlenecks and there are gaps, and see how we can strengthen that. So overall, that is the main discussion point today, and I'm very glad to see most of us are on board. People who have a lot of experience in designing programs, HIV, TB, malaria, and community systems programs across the region. We have people who have long-term experience. We have engaged with these systems. And I think also some of our colleagues who are on board today are colleagues who have been engaged before in policy formulation and implementation at country level, even at community level. So we have a lot of experience in the room today. So I'm glad this is a topic that can easily be discussed. So without wasting so much time, and sorry for taking too much time to introduce this, we would like to look at the first agenda item is to just take 2 steps back and do a sort of a recap on what do we mean by integration, what are some of the things that are already happening. Once we have framed that, then we can get into presentations from ACT, where we have our colleague Imoro Abudu, who will take us through a session on trends, good practices, failures in service integration. This is based on the experience from their end. Then we will look at the linkages with RSSH and PHC reforms. We know these are now systems issues now. We are getting to the systems issues because integration is not just in specific service delivery actions, but also how do we coin the systems to be able to handle integration. Then we will also have implications for community engagement. What does that mean now moving forward for us as communities and the communities that we work with? So these are the 3 areas. We have 3 able speakers, as I had mentioned. Imoro Abudu will be leading us on that. Then we'll also we'll get to hear from GNP Plus, where we'll have Cedric that will come in, and also from our colleagues who are implementing and designing malaria specific programs, that is a CS4Me, that will be represented by my very, very good friend and brother Ayo from Nigeria. Very experienced civil society organization that has championed the malaria response in Nigeria. And I think we all understand the impact of malaria in that part of the world. So getting to hear from people who have hands-on experience and looking at service delivery and integration, what it meant for them. And I mentioned malaria. I think they have been in integration primary healthcare before. Most of us who are designing TB, HIV programs. So we'll also get to hear from Ayo and get those experiences. Then we will also transition to a panel discussion where we'll look at integration, equity, and community leadership. We'll have a panel discussion. Some of our colleagues will be within the panel team. We'll be able to hear from Dr. Muko. Then we also, the panel will also consist Mathe, Masupa, Anil, and from Global Fund, Angela, and GMP Plus, Cedric again will be part of that panel. And the panel, as mentioned, will be more focusing on looking at integration, equity, and community leadership. Then we will open up the space for now reflections, questions and answers, in case we have anything that we want to comment on, anything that we want to clarify, or when there's anything that I think was not very well understood, we should be able to provide an opportunity for us to come back together again and ask those questions and provide and get some clarity. Then we'll have my colleague Lisa will come in and summarize the discussions, and and we can close. So that is the agenda for the day. Sounds like it's packed, but not really packed. I think we should be able to dispense of this agenda with ease. And I think it's a very interesting topic that will get all of us thinking and also share information and also benefit from this discussion as we design our programs. As I've mentioned, I think all of us are in one way or another in their process of designing their county program. And I think this is one of the best opportunity. If you have any questions that you can ask. So please also use the chat box so at least we can get more questions and we will analyze the question as we go and we should be able to provide the answers. And where we don't have answers, I think it is our responsibility of the Learning Hub to interact with the other colleagues to get the right answers for the questions. Thank you so much. I would like now to invite one of our colleagues to just set the scene. This is Madam Maureen Murenga, my friend Maureen Murenga. I don't know if she's online.
Yes, I am.
Oh, thank you. Thank you, Maureen. Welcome. Welcome, Maureen. Thank you.
Thank you very much, Beku, and thank you everyone for joining. I'm trying to share my slide. So I just want to, first of all, highlight that the issue around integration is as vast as we are in this meeting, and countries are approaching it differently. But something that really triggered the conversation around integration was the stop work order. And so countries actually did not do what we mean by integration. They just shifted people to primary healthcare in a very, like an emergency setup. So the communities delegation developed a paper on what works or integration that works for communities. And this one was developed because of the understanding that integration is not an emergency response. Integration should be driven by need and not by resource constraints. And integration that does not include communities is actually not integration. And we may end up losing the gains other than what is it called? Than benefiting. So we also know that we cannot run away from the conversation of integration because it's happening. We needed to jump into the ship and you know, be with others and discuss from inside. So we developed this paper that has been shared widely, and also I'll just highlight some of what is in the paper that we developed around integration that works for communities. So, like we know, the Global Fund is now pushing countries to integrate. It is part of what is written in many allocation papers. So the integration is around HIV, TB, and malaria services together. And also there's a push towards increased domestic resources for the three diseases. But we also realized that Global Fund only raised 12.64 billion of the 18 billion it needed. And this means that every decision about how to integrate will really matter deeply for communities. Remember, we are now in this ship because number one, resources are scarce, there's need for transition, there's need for countries to take up, and also the promotion of One Health. So one of the issues we saw as a challenge is with the integration, if it doesn't involve communities, is that people can lose access. When services are integrated badly, people who already face stigma, or people who have to take long distances to facilities, people who experience legal issues, they're criminalized, can find it even harder to get care. And then we also know that if integration is not done correctly, trust can be broken down because there are people who access services in places they trust, and just shifting them doesn't help in improving access, but it actually diminishes access. So we know that, again, that the quality of service can be compromised because we know people need different skilled clinicians to provide the different services such as HIV, TB, and malaria, and sometimes mixing them wrongly will lower all the quality of all the three diseases. And then we know that this will significantly affect communities if it's not done well, because there's a call around absorbing communities into government systems. In my country, they're saying community health workers, what is it called? Mental mothers should all be under the government system. But this makes us lose the voice and independence. And then, of course, most governments were not ready. And so moving funding to governments quickly could leave out the population that governments have never properly served. So 4 things we believe as a delegation is that communities must lead in the agenda of integration. So people living with HIV, TB, and malaria, we know what works. We are not just people to be served. We must help to design and run the programs. Our knowledge, our networks we've developed over the years are what makes the health system reach people who need to reach them most. And then the second thing we believe is that community organizations are the foundation of integration. So we know that for integration to succeed, the community system strengthening must be a priority. Donors and governments must invest in organizations that communities have built. So without proper funding for this organization, integrating services together will stay shallow. It will be shallow, and programs will overlap on paper, but not actually reach the people that the programs are intended to reach. The third thing we believe is that sustainability means more than money. So the issue around integration for sustainability, it should not be driven by monetary implications. So handling health budgets to government is not enough to help us reach where we need to reach in terms of ending the pandemics. Communities must have legal rights, the space, and the tools to keep watching over the government, health commitments, and to speak out when things go wrong. So our voice shouldn't be shrunk because we are integrating programs. And then the fourth thing that we believe is that no one should be left behind or hidden. So people who face criminalization or deep stigma, such as sex workers, people who use drugs, gay and bisexual men, transgender people, for these communities, people in prison, integration must never erase their safety, privacy, and trust that they have had on dedicated community services that have been provided for them. So we tried and looked at what a community-led integration would look like. So we know that we have had drop-in centers, we have had community organizations that have been providing services in our communities. So we can integrate using these community spaces. Integration should not only mean that we have to use government facilities, especially if we are also considering communities that are criminalized by the constitutions of some governments. So a single community system can run where you can have HIV testing, TB screening, malaria diagnosis, sexual and reproductive health services, and referrals in one visit. And these work best when organizations running it is known and trusted by local communities. You'll find that people who trust those organizations or who fear stigma and criminalizations will feel better when being provided for services at those one-stop community health hubs. And then we also look at integration from a peer navigators angle, where we know that peer navigators work with clients or work with their peers and support them in terms of accessing services. So if for example, someone tests positive, they can connect you to TB screening, and if you're pregnant, they can link you to malaria care and PMTCT services. So they understand the barriers. The beauty about being connected by peers is that they understand the barriers you face because they have faced those barriers in the past, and they're able to inform you and to better guide you. And then we also know that integration should be supported by a very strong community-led monitoring system where we track how well the services are provided, who is being missed, and whether people's rights are being respected. And we need the CLM structures that are able to feed information back into the systems and problems are fixed quickly so that they don't become crises. And then we also we believe that a community-led integration must have referral networks that do not drop people. So we have referral networks where we know that people move safely between one service and another. For example, a person who tests positive for HIV is connected to TB prevention or TB screening. A pregnant woman on malaria treatment is enrolled in antenatal HIV care, and nobody falls through the trap. So that the entry point, if someone came for malaria services, we are able to offer a full package of care, ask questions if they're pregnant, offer testing for them, and link them to elimination of vertical transmission services if they are supposed to be linked. So there's someone who said if integration does not start with community, it is not integration, it is absorption. And absorption without protection means loss. So in the previous grant, 5 to 7% of Global Fund grants went into community organizations. And that is too little. If Global Fund is true to commitment around integration or to support community-led integration, if countries want to do it right, then we need to increase the allocation that goes to community. So if communities are underfunded, they will not be able to pay rent, salaries, or keep their doors open. They are not going to be able to support people who are struggling with stigma and criminalization to access services. Peer support work, like I've mentioned in the previous slide, will not happen if we have short contracts with no job security or benefits. Community health workers who are asked to continue volunteering is not sustainable, it's not predictable. Initially, we were volunteering because we thought we would die, but now that we are not dying, we have bills to pay, we have children to raise, and therefore community health workers must be waged. And then advocacy group risk shutting down if there's a single funding cycle that goes through government. So what we need to be properly funded, or what we are calling for that should be properly funded, especially in GC8, is multi-year co-funding for community organization and not just project costs. We are also asking that the support for data tools and digital system for us to better do CLM and monitor that the quality of services are not compromised and that people are not left behind. Communities need training that builds long-time organizational strength, not one-off trainings or 3 days in a boardroom. We need legal support to operate and register officially. We need networks to learn and share with each other, so we need to network. And we need resources to monitor and report on service quality that I have mentioned before. Another thing we have been asking for as the community's delegation is direct funding to community organizations. And there's no time that is ripe more than now when we are talking about integration and we want integration that works. Community organizations must be independent, they must be supported, their funding must be predictable and long term, not short 1-year contracts. And so we know that when money passes through government, communities will have little to say in how programs are designed. Reporting deadlines for government may not match for communities. Community groups are left out in key planning meetings. Like, for example, right now, there are conversations around transition that are happening with the ministries of health and ministries of finance, but communities are not at this table. And when they're talking about transition, they're just thinking about government health systems. Nobody's talking about how do we sustain community health systems to live beyond Global Fund. What kinds of investments and programs can we put in those programs to enable them sustain long after Global Fund has transitioned out, especially from countries that are transitioning out in GC8 and GC9? Then, if governments have the resources and we don't, accountability goes upward to government, not back to communities. But when we receive funding directly, we are more stable and can plan ahead. We can provide accountability that goes directly to the communities we serve. We will have more space to try new and creative approaches to integrate. And then we will also, key population groups can access funding without going through systems that exclude and criminalize them. So, like I said, sustainability is more than government just taking over. Handling health budgets to government is just one piece of sustainability. So, real sustainability that is supposed um, to be realized from the integration we are talking about needs to have financial sustainability. Government needs to take more than just the cost of health programs, and communities need to hold them accountable for actually spending money as promised. Governments need to absorb community health workers. And then we need systems that keep working. We need communities that are not compromised in the process of integration and sustainability so that we are able to still hold our governments accountable. Some of us come from countries where if you stop making noise, you die. And then community organizations have proven to be a tool that is important in the response to the 3 diseases. So we don't want to kill community-led organizations. So I'll go, that takes me to integration that should not erase anyone. So there are people that are already criminalized by many of the systems in our countries, such as sex workers, drug users, gay and bisexual men, and transgender people, and people in prison. So integrating services into public health facilities carries specific danger of this group being invisible. I was talking to some of my colleagues who are key populations yesterday, and they were telling me they feel like they're being erased out of the space, that there are no conversations that are directly favorable to their conditions to accessing health services. And if we go into integration, and integration that is being described as taking services into public health healthcare programs, then we will exclude these populations even more. So evidence has shown that when those dedicated community services that we have historically provided, if they are merged into general clinics without proper planning, fewer people will come for care. There'll be a lot of stigma from healthcare providers, and more people will stop treatment and will stop accessing prevention commodities. So 6 things that must never be compromised when we are talking about integration. Community decisions. So organizations that are led by people living with diseases and key population must decide how integration affects their own programs and not to be told by others. So they must be at the table when these programs are being designed. Another thing we should not compromise is protected funding for especially key and criminalized population. It should be predictable, it should be protected, and it should be sustainable so that we are not losing the services provided by these populations. And it must be ring-fenced and, if possible, accessed directly, not filtered through systems that exclude them. And then we want integration that has no added legal risk. So integration should not make it dangerous for someone to seek services. Our data systems and the referral pathways must protect people from legal exposure, from stigma, and from other forms of criminalization. Integration must keep the specialist skills. The peer models have been invested in. People have been trained. People have developed skills and expertise over the years. Integration should not kill this kind of skill sets that we have invested in. So those knowledges have kept our populations adhering to treatment, seeking treatment early. So we need those ones to be preserved. Integration should protect people's safety and privacy. So in as much as people are being taken to the outpatient department, their confidentiality should be still a priority.
Sorry, Maureen. I think, Maureen, you are experiencing some connection challenges. Can you hear us? Maureen, can
Must
you hear us,
always be
Maureen?
protected.
Sorry,
Communities
we
must.
had sorry, Maureen, we had lost you for a split of a second. Are you able maybe to?
Okay.
Yes, yes. Thank you. Now we can hear you clearly. Thank you. Go ahead, please. Sorry.
Okay. So yeah. So what asking the Global Fund to do is we are still asking for direct funding to key and criminalized populations so that they can stay independent and accountable to people they serve. We are still asking that even as we talk about integration, it should be the one that invests in community systems in every grant so that community platforms can anchor programs now and into the future. We want a predictable kind of resourcing, a predictable system, one that is sustained beyond grants so that we are able to program for the future. We are asking for support for social contracting where possible so that community groups can keep doing their work even as donor money reduces. We are asking for protected funding for key population, even within the country allocations, because these are the most excluded populations, and we are asking that if their resources are protected, then they are able to stay safe and continue receiving care within their drop-in centers. Asking for a funding of committee-led monitoring, which will continue giving us an independent oversight that outlasts any single funding cycle. And then we are also asking that even as we have conversations around integration, we should build in the difficult conversations around removing legal barriers so that we have more people accessing services at the primary healthcare without their lives being endangered. So we are asking for the Global Fund to make community-centered integration the official standard for GC8, not optional. We are asking that every grant is required to include a proper community systems budget to create direct funding pathways for community-led organizations, especially those that are serving key populations, and to issue clear rules protecting criminalized populations in any integrated programs, and to set up dedicated way for communities to report harm and get action. And also for the CCMs to make sure that communities, including those living with HIV, affected by TB and malaria, and key populations are genuinely involved in grant design and not just consulted. Conversations with us should not end at country dialogues. We should also ask for CCMs to start having conversations around pushing laws and policies that allow community organizations that are criminalized to register, operate, and get government contracts. We are also asking that the CCM commissions communities to monitor integration quality and feed findings into grant reviews, and also build on plans on how governments will fund community organizations, especially those that are fundable within the government systems. And so for the governments, integration doesn't mean taking donor money to do your business. It also means government should put in their own resources into the health systems and also be able to pay some of the community workers that are within the health system. That government should work towards removing legal barriers, and that's the only way that integration is going to work, so that people are not criminalized and they're allowed to operate and register within the country. Government should use data from CLM in national health planning and not just government data, and ensure that integrated services reach most marginalized people as domestic funding grows. So I'll conclude by saying integration is not only transformation if integration is only transformation if communities lead it. So GC8 is giving us a chance to change not just how programs are funded, but the relationship between health systems and the communities they are meant to serve. So we must be the architects and not just the audience. Community system strengthening is essential, not a budget line to cut. Sustainability means communities can keep holding governments accountable and not just governments holding money. And GC8 is the moment to make the invisible work for communities and fund it properly. So we are not asking to be included in integration. We are asking to lead it. The difference matters because what communities build for ourselves, we sustain. Thank you very much.
Many thanks, Maureen. That is really elaborate, and thank you so much for setting the scene. I think you've covered most of the things that would have given us the best platform and a point of a starting point for us to be able to engage in this discussion. Thank you so much. This is really elaborate. So guys, if you have any questions, you have any comments that you have, please use the chat box so at least we can be able to pick your questions and see the things that we need maybe to respond to. And Maureen and my colleagues will monitor those and we'll respond as we go. So thank you so much, Maureen. I would like to, as part of that session, I think we just needed also to look at what is happening already. But in the interest of time, I'll go very, very quickly to see which areas in the region the countries have already started integration or integration is happening and some of those processes have been accepted at that level. So we've seen the first, I think Maureen gave us a very good background. We are starting from the point of money. That's the driver, okay? So we need to have most cost-effective programs. And one of the answer, not the best answer, but one of the silver bullets is integration. So that integration helps us to achieve cost effectiveness in our programs. Then from that understanding, we are moving to what is the best platform within our national health systems. We've looked at primary health care as the entry point. So we are coming from cost effectiveness, reduced funding, and how do we sustain health programs at country level. So we're moving from that is as a justification. Then we go to what is the best entry point, and we in our national systems, I think we have the best or a system that covers most populations, which is primary healthcare at country level. So using the primary healthcare as a platform for integration, I think that's why we are anchoring it moving forward, and most countries in the region have done that and have encouraged programs, have encouraged investment in primary healthcare. And most important, I think a number of countries have actually put mechanism in place to see community engagement and community leadership in decision making at primary healthcare level. So I think their communities are involved, and as Maureen mentioned, that integration without communities might not really work. So what are some of the things that are happening? Areas that we've seen integration, we've seen like integrated screening and diagnosis, HIV, TB, I think scaling up that, malaria and other sexually transmitted diseases, getting into NTCs and all that. So screening and diagnosis is one area. The other area is looking at the treatment and care. So we have one-stop shop. And another. Thank you, Maureen. Thank you, Maureen. Lovely voice. Thank you, Maureen. Then we also have community level integration. At community level, I think this is what affects us most. What happens to the healthcare workers that we have, the community health actors that work at community level. Integration at that level is also working. And I think, to be honest, we as communities, we've done this fairly well to some extent. So the community health actors, can they still provide community level malaria services, TB referrals, HIV service delivery at community level, and other public health challenges. So we need to scale up and equip, strengthen the community health actors that we work with, so that they can be able to integrate services at that level. Then we're looking at the systems again. Maureen has mentioned this, supply chain management. Is it still operating in silos, or have we integrated that as well? Data is another system issue. We also need to look at that, and that has started happening as well. And also, I mean, the overall health workforce at level 1, 2, 3, and 4, primary healthcare levels. Then policy, which is now where I think is starting, where integration has been encouraged. And I think most of our national strategic plans have covered that, and they've pushed us towards integration. So I think community perspectives, Maureen has covered very well the fears. places where I think we thought as we try and put this in place, we have started experiencing challenges. She's mentioned issues around stigma. I think we also need to look at workload at some of the primary healthcare system level. So we as we look at this, there are some of these issues, the bottlenecks that have come up as we implement integration. I think Maureen has covered them very well. So without wasting much time, I'd like to get to our next session where we need to look at invite some of my colleagues to now lead us into the discussion around integration of HIV, TB, malaria services within primary health care. We've seen that's the entry point that we need to go in. And I would like to invite Imoro. I think Imoro is with us, has joined us. Imoro from ACT Africa, based in Ghana. Imoro, can you hear me?
Yeah, John, I can hear you.
Thank you, Imoro. How are you?
I'm fine, are you?
Thank you. Please welcome on board. Thank
you.
And I pass the mic to you.
Share my screen?
We can hear you, but we can't see your screen.
Can you screen my screen now?
I think now it's coming up, and I pass the mic to you. Over to you.
Okay. So thank you very much, John. And thanks, Maureen, for saying almost everything that we need to know today. Yeah. Maureen has covered almost everything. Thank you, Maureen, for doing that. My name is Imo Rabudu, and I work with ACT Africa, and I work as a program director. The global health landscape is shifting fastly from vertical disease management to integrated health systems. So like Maureen said, there's a need. We quickly look at the shift, what is inherent in it, what are the advantages that we can take as communities, and what role, especially leading role, we can play as communities. So my presentation will just cover what we need to know in the African perspective, what community is doing at the primary healthcare and the RSSH level.
Yes, Imoro, if you can put your slide on a slideshow, that would be lovely. And also, we have very limited time, so I will cut off some few minutes from your presentation, please. I hope you don't mind.
Is it okay? Is it okay now?
Yes, Imoro, it's okay now. It's okay. Go ahead.
So let me take it quickly. So look at the TB problem in Africa. 1 in 3 TB cases still undiagnosed. Ghana stands a key example on this. We look at 70% of Africans seek care at the primary health centers. Yet TB cases are rarely available at the primary health care level where patients arrive first. If you look at our hospitals, TB diagnosis remains centralized. Treatment access is concentrated far from where most patients live and first seek care. Then let's look at our experience with COVID-19. Vertical TB programs collapsed under pressure. When hospitals were overwhelmed during the pandemic, stand-alone TB programs had no fallback system. These are lessons we are carrying into integration. Now looking at what RSS stands for, it's a global fund framework designed to build health systems that are strong enough to end TB, HIV, and malaria, while also responding to new health threats, and achieving universal health care. And what are the elements here? End TB, HIV, and malaria. It seeks to equip countries with the systems needed to eliminate the 3 major infectious diseases burdens. It also seeks to respond to new threats, build adaptive health systems capable of absorbing shocks from pandemics to emerging outbreaks. Then, last but not least, it seeks to deliver equitable, accessible care through strong primary health care as the foundation of universal health coverage. What does integration actually mean? We'll look at it from two phases. It means we should stop running TB as a stand-alone vertical program, isolated TB clinics, separate supply chains, programs that collapse when the broader system is under stress. That is not integration. What then is integration? Let's start delivering TB services through the broader health system, especially under the primary health care. Primary health care facilities, community health workers, integrated care that survives disruption and reaches more people. So why do we have to integrate TB into primary health care? John, you mentioned some of the advantages already, but I'll just add a few. We need access. Case detection rises when primary health care facilities screen for TB, bringing services directly to where people already seek care. Second point, we need resilience. Integrated primary healthcare systems keep TB service functions when hospitals are overwhelmed by crisis, especially during the COVID-19 period. They also need efficiency. One healthcare worker, one visit, screens for TB, HIV, non-communicable disease, and maternal health simultaneously. So the one-stop shop will ensure that on a one visit, you can screen for TB, you can screen for HIV, you can screen for non-communicable disease, and you can go into maternal health care systems. So that is one of the reasons why we need integration. Then let's look at the pillars trying to bring RSSH with TB and primary health care. Let's look at the effect of bringing them together. First, we look at the RSSH pillar, which is service delivery, TB diagnosis, treatment at primary health care, not just hospitals. An example is Nigeria telehealth plus rapid diagnostic at the primary health care level. And we look at the workforce. We need to train primary health care workers, nurses, community health workers to collect sputum, start treatment. And then at the national level, the Africa Center for Disease Control, the tax is shifting to community health workers as continental model. Then we look at the laboratory. And we can use a hub and spoke model where the laboratory is well furnished that can take care of all these three diseases at a go to ease costs and then to be cost effective. So we need to strengthen lab networks for all primary healthcare conditions. Then we look at the community system like Maureen alluded to. Healthcare workers do contact tracing. They reduce stigma if they are involved. An example, a classical example is the Reach Ethiopia project, where we had TB cases doubled as a result of what they did in Ethiopia. The primary healthcare reforms center community health workers will all be trained, and then case finding will increase. They will look at data system. The primary healthcare electronic data TB feeds national program, and this is where we make use of data interoperability. At a click, you can access data on a patient regarding his TB status, his HIV status, his malaria status, so it makes the decision-making very quick and easier. And data interoperability is a necessary key tool when we're talking about integration. They will look at the governance system. Already, you talked about the policies. We need joint policies. We need new policy frameworks we need to look at the legal frameworks so that we can look at how we can have joint TB at the primary healthcare planning and budgeting for TB, HIV, and malaria. And then we can look at system where primary healthcare becomes a vehicle for TB tracer. Then let's look at what integration has done in some of the African countries.
Yes, Imauro, as we look at that, you have 2 minutes. Sorry about that.
Okay, so let's look at Nigeria, Africa. The Center for Disease Control recognizes primary health reforms as a continental model. In Kenya, pediatric TB services decentralized to 32 primary health care facilities, which has directly improved case detection rates for children and reduced barriers to early diagnosis. In Ethiopia, like I said, the REACH initiative engaged community and religious leaders as TB champions, and this initiative gave us wonderful results, doubling case findings in Ethiopia. Then let's look at how we can align TB to a strong health system. We look at 5 cardinal points here. The WHO policy brief. We look at the use of every contact screen for TB during antenatal care, visits, child health checks up, and non-communicable disease consultations. We need to bring care closer to the people also at home. TB diagnosis and treatment delivered at the nearest community clinics. Then, like Maurice said, there's a need for community ownership. Community has to lead and own the program. When we lead and own the program, sustainability becomes a much easier way to override. So, to conclude, because of lack of time, let's look at what then is the right approach. But first, what is the wrong approach? The wrong approach is don't build a TB system. The right approach, build a strong primary health care system that finds and treats TB as part of routine care. So for policymakers, we need to fund, we need to integrate, we need to scale up, and we need to formalize the relationship between TB, HIV, and malaria. Thank you very much, John.
Thank you. Many thanks, Imauro. That was our colleague, ACT Africa, based in Ghana, but working across the region. Thank you so much for that. I would like to quickly transition to one of our colleagues, very knowledgeable, Cedric, to give us the perspective from the HIV programming. What does that does all this mean within the HIV programming? Cedric, can you hear me?
Yes, I can hear you, and can you hear me?
Yes, we can hear you loud and clear. Welcome, Cedric. How are you?
Thank you so much. I'm good, thank you.
Good. So I pass the mic to you, please.
Yes, and I think I want to share my screen and
That's okay. That's okay. As he's sharing his screen, so this, I think the structure of this discussion is that we've looked at some of these, what does it mean specifically for TB programming service delivery? Now we are transitioning to HIV service delivery. What does all this mean in terms of service integration? Yes, Cedric, we can see your slide. Please go ahead. And I will
yes,
have to please steal some few minutes from your presentation because we started a little bit late. Sorry about that.
no worries. How much time do I have? Like, so that I can monitor myself?
You're able to do in slightly less than 10 minutes, 8 minutes?
Oh yeah, no, that's no. I would do less than 10 minutes. Yes, so thank you so much, John, and thanks for extending the invitation to GNP Plus. My greetings to all the colleagues who are joining from everywhere, and I'm happy to be sharing this presentation on behalf of the GNP Plus team, but also the people living HIV networks who participated in this survey. What I'm going to share today, as we discussed the area, is the what we call the people living HIV minimum requirements for integrated HIV services. You would probably wonder why the people living HIV minimum requirement. The reason is very simple. we organized in 2025, right after the announcement of the US funding cuts. We organized the People Living with HIV Leadership Summit in Nairobi, Kenya, where we had more than 80 participants from 18 countries, 6 regions. The question in that meeting was, what do we need to do collectively as communities, but more specifically as people living with HIV? We're seeing, I think Maureen mentioned this in her presentation, we're seeing many disruptions in terms of service provision because of the funding cut, but also there was a distress in terms of information. And where are we heading to after the funding cut? So what is the role of people living HIV leaders, but also how can we really interact with the governments that are trying to fund solutions for their citizens? Combining those questions through the discussions we had in Nairobi, one of the most important recommendation was to define the minimum standards of integration for people living HIV, and what the people living HIV can do as an advocacy at global and national level. So we got this recommendation and we took it seriously as GNP Plus, and then we went to develop the minimum standard. But also, while we thinking on how we're gonna do the minimum standards, we continue the discussion through different conversation. We had 23 online convening of people living with HIV networks and communities, but also we had different podcasts where we invited like-minded community and leaders to reflect on the implications of the funding cuts, but also what is the possible way to define the people living HIV integration asks, because everyone was afraid on what is going to be when we lose the specialization of HIV services. I have managed myself to put out a QR code should you, for people listening, want to listen to these different podcasts. They're very interesting topic. You can probably scan the QR code and then later on you can listen to those podcasts. I promise you that you will learn more than also from the presentation. Then what are the minimum requirements and how did we come up with these minimum requirements? This is the whole report, which is the core of this presentation. Again, I feel like I'm loving to have a QR code just for quick reference on documents. In terms of what the study objective, why did we do this minimum requirements the study? Why did we want to collect this? As I alluded before, we wanted to determine the minimum requirement, ask the needed for a responsive HIV integration service at primary health care. And that's also taking into consideration the sustainability of treatment access. Remember, if you can reflect back in April or February last year with the distress in terms of service access and HIV treatment with more information, people were very scared about their treatment access. But we also wanted to understand what would people living HIV networks do, particularly at community level, but also when we think about service delivery and how, which I think Abudu was mentioning, bringing close service close to the household. And but lastly, the objective of this defining the people living HIV minimum requirement was to really solidify, affirm the people living HIV leadership through the network and service providers, just to make sure that the integration remains person-centered. I will quickly give you some key data from the study, and then I will move to what are those minimum requirements. So briefly, the methodology was we did a qualitative and a quantitative survey, and we had like 1,800 respondents from all over the world. These were collected electronically, but also in terms of qualitative study, we had 9 key informant interview. These were ranging from country networks leaders, but also global leaders in the HIV response. Some interesting data, age distribution. I won't take that much long. Of course, 25, 34 was the leading team in the study, but also we had a couple of other groups, 35 to 44, with 35 to 44 and 45 to 54, probably equally the same. But that was not the most important message here. Is a range of people responded to this survey, which gave us really a direction to understand what people are expecting from the integration. So in terms of distribution, so we also tried to understand which subgroup in terms of community people belongs to. So we have we try to understand the MSM, people who use drugs, sex workers, but also transgender people, where among people who responded to a survey, the quota that belongs to the communities. And then one important fact, and then this is going to match with exactly what Abud was saying, is that we really, in terms of access to health services, we find out that public hospital is the most common facility type for, possibly one. There's like a 59% and 59% for female and 59% for male as well, with 38 for non-binary people saying that the public hospital are their common facility type. But when it comes to HIV clinics, we find that these are 72 and for female, 79% for female go to HIV clinic for the HIV services. That says something in terms of integration, but also if you think about the funding landscape and how things were changing, it shows that the integration is going to have an impact in terms of how people access services. So briefly, what are those minimum asks? So we have about 7, and I think most of them already have been mentioned by, I think, Maureen, but also Budu kind of alluded to this. The institutionalization of plan to engage people. We don't want to have this as like an ongoing advocacy all the time, but the ask is, when we think about integration, you have to think about integration of HIV service, and you have to think about the networks as a key partner into the integration process. But also, we understood that the context, this is the second ask, the context of integration in country have a different context. So the local context is very important. And clearly defining what is integration, trying to aim for, because you can think about the populations or the most dominant disease in any given country. So the context can be different, can differ from country to another country. And we want to make sure that we are not saying like integration need to look alike everywhere, but the context need to be very much specified, but also keeping in mind integration, working with the country networks of people living with HIV, because these are the people who receive the services. And of course, the third ask is about diversity, because you cannot just take people living with HIV as one individual. As I already showed you in terms of the distribution of age of people who responded, we have different group, but also different population within the people living with HIV. So the diversity, when we talk about people-centered services, has to be kept in mind when we design the services. This is also linked to the stigma and discrimination, which is the 6th ask. I'll come to that later on. And the 4th one is about comprehensiveness of the integration. We've been saying this. I think this also it's not only about the integration, and I think also Maureen mentioned this. People living with HIV, thanks to treatment, they live longer, but also catching up with NCDs. These are the type of things that are coming into people living with HIV lives. So when we talk about the integration of HIV, we need to make sure that we are not integrating only, for example, the treatment access or the testing, but all the other needs that possibly people living with HIV would need to be at least integrated into primary health care so that there is no disruption, or you are not sending people in different places. Why you were talking about integration. And of course, the system, the health system strengthening, we think this is not even, we ask it, but we know also countries think about this. We don't want a shaky system where in some way or another people in some region, this is providing, some other region people are not receiving the same services as others, or possibly where we have not trained community health workers that could help, or maybe they have the capacity to treat or provide the services as required. And the sixth, as I mentioned, is stigma-free. Stigma and discrimination-free. I won't really take long on this one, but we understand why we mentioned this, diversity, but also HIV stigma and discrimination is still one of the burden in terms of the HIV service provision. So when we do integration, we have to really take into consideration that it has to be stigma and discrimination-free. The last but not least, and which I think is the most important for us when we reflect back on what happened last year, we believe that if we talk about integration, government should take the responsibility of purchasing HIV treatment as a minimum. We don't want to hear that there's this disruption of HIV treatment access because the funding there. This should be a responsibility of the country, and we should never hear any stock out anything. And then also linked to this is the message behind when people are taking treatment very well, there's viral suppression, but also there's less transmission because undetectable equals to untransmittable. Yeah, and then just to finish, next to the study on minimum requirement, we did 9 case study in different countries. I won't take long to explain this. I also came up with the QR code. If you want to have this, I can also put them in the chat as soon as I finish my presentation. But these are the documents that we believe will help to shape policy, and then it can be used by any relevant stakeholders at country level who are thinking or planning to implement the integration of HIV service. So in conclusion, people living HIV networks are crucial in the HIV integration if we want to have an integration that is sustainable but also person-centered. And also it has to reflect and the needs of people living with the HIV. So I will finish here. I hope I did not take that long, and I'm happy to respond to any question. Again, this is a brief presentation of the study. You can find it on the GNF's website. I will drop the link in the chat. Thanks so much, John. Back to you. You're on mute.
Many thanks, Cedric. And thank you also for sharing the documents. We should be able to access the study, the results, and I think it provides very good insights. I would like us to quickly transition to now bringing in our malaria colleagues, people who are programming around malaria. And we are very glad to have Ayo, my brother Ayo, all the way from Nigeria. Ayo is an executive director at Acumen, and the civil society organization designing and implementing malaria interventions in Nigeria. But Ayo also participates in a lot of regional and global discussions and interventions, and is part of our regional leader in supporting malaria and community system strengthening. So Ayo, please, I'd like to pass the mic to you. What does it mean in terms of integration and looking at the CLM and the leadership of communities in integration?
Okay, thank you so much, John, and thank you, colleagues, for having me be part of this great discussion. Much of what I had wanted to say has been said, so I will not take that much time again. But let me start by saying that as we go to GC8, We are looking at the reality on the ground of a severely constricted global resource architecture. We just do not have as much money as we have for GC7. So one of the ways we can keep on providing good quality services for the communities and for people who require those services is by integration. We need to be able to do more with less money. One question we usually ask ourselves in Nigeria that I usually throw out is, now that we are saying there's less money, do we then tell our people just go and die because we don't have money? No. So we have to devise ways and means of even improving the quality of services in the face of reduced funding, which is the reality. And then when we talk about integration, this has been said, I think, by Maureen and John, but it bears repetition that integration is about people. It's not about money. It's not about system. It's about ensuring that people and communities are at the heart of healthcare interventions. It's not money. It's about people. And we're talking now, remind ourselves that even when services are government-led, they have to be people-focused and community-centered. Whatever we design, if it's not bringing better quality service to the people, then we have not succeeded. Now, talking about integration and the roles of the community and community-led monitoring, let me give some examples. Or let me say this also. In Africa, and where we all come from, everyone comes from a community. I'm not talking of a geographical community, not community of care. We have our towns, we have our villages, we have our counties, our regional leadership structures in Nigeria around community-led monitoring is that we have been able to bring the community leaderships into healthcare. Oftentimes, we work with the communities, we go to those communities and we work for them, we deliver services for them, and we do things for them. They are not part of the architecture. They are not part of the design of the project. They are not part of uh, the policy making at that level. And so when we have done whatever we need to do, which is very good, and we exit those communities, we find out that the intervention stops. Community-led monitoring means that actually the communities are part of and they lead. They take a leadership role. So our interventions in integration is now empowering the communities with knowledge, empowering them with access to decision making so that they can be able to make informed decisions and informed inputs into healthcare issues. Then our community-led monitoring activities is not just about gathering data. It is about gathering data from different stakeholder groups, from caregivers, from community leaders, from community people, from service recipients at the community level, at the primary health care level. But we do not just gather and analyze information and submit the information. We analyze the information, we synthesize, analyze, and then we use those information for advocacy at that community level. Because a lot of issues are going wrong is at the PHC level, at the county, the district, or local government level, however you call it. So when we just collect information and we send it forth, before the results come back, it takes many months and community members have suffered. So we must be able to situate the response to issues as close to the community as possible. Community members must be empowered by us to be able to analyze these issues and be able to take responsive actions to resolve issues close to where they are. And it means that they must participate in all the decision-making process at that level. Now, going forward, when we look at what the problems are at the primary healthcare level, what we find out is that all these issues around resourcing, or of course across Africa and all our regions, we all know that one issue we have is we don't have enough money, we don't have enough resources. But sometimes it's not just about the resources, it's about the equitable distribution of the resources. For instance, in Nigeria, working on malaria, we see that much of the resources that there are situated in the urban areas, in the accessible areas, whereas the people who need these resources more are in the rural, hard to reach, the poorer, the poorer sections of the community. What we do and what we need to do is our advocacy to ensure, one, we empower these people to be able to ask questions, to be able to advocate. Number two, we speak for them so that there's more equitable distribution of resources. It's not just about the quantum of resources, it's about who gets what. Then talking about human resources. For instance, many health workers, we say, oh, we don't have enough health workers. But you go to the city, to the townships, to the headquarters, you find lots of staff bundled around some PhDs. Then 10 kilometers outside of that, you don't find anybody. So why is it that the areas that are well-to-do have surplus of staff, and those who need those staff, who need those resources, they do not have? It boils around equitable distribution of human resources. This is another area that our community-led monitoring and community engagement should make us active. Let's advocate that the resources should be spread. Then talking about human rights and human rights is integrated. And all of this is I'm talking about is in the context of integration. For instance, when the community health workers and the professionals are available, they serve everybody. And so what we have done is also ensuring that human rights issues are integrated across HIV, TB, and malaria CSOs. Actually, we have integrated our tools. We are using the same tools that is integrated. So whether you are a civil society organization from HIV constituency, from malaria constituency, from tuberculosis constituency, anywhere you are using those tools, you should be able to ask questions and make impact on issues that affect everyone. We have also integrated the community participation in the supply chain so that rather than whether you are from the HIV community, TB community, if you, for instance, see that the community members are not sleeping inside the nets, mosquito nets, or rather using the net for fishing or farming, whether you are from HIV or TB, you are affected by malaria. So you ask questions and ensure that right things are done. So by integrating our response, I do not say, for instance, if ACOMI members, member organizations, they do not ask questions about malaria alone. They want to ensure that whether you are from HIV, key population, whatever it is, you are a community member, you are entitled to good quality services. So by balkanizing ourselves and not integrating even ourselves as civil society, we are losing out. Let me make the last point here and stop. I gave myself 10 minutes. Then the other thing we integrate or we need to strengthen integration is the community and civil society participation in developing domestic resources. A lot of time we look to the national government and international donors for domestic resources, but within our own small environment are also small pools of resources that we can mobilize to support what the donors are bringing. So those more catalytic funds, we are focusing from civil society on those. Those are things that the Global Fund will not do no matter the quantum of money they bring or the federal government of Nigeria. But by going to the local, small private sector, the small philanthropic organizations, the religious organizations, the traditional organizations, and everybody bringing what they have. The other, even volunteering, the churches and mosques, they send their people to volunteer. We are the services from government falls in place. So in that case, and all of these things working together and speaking to, oh, I almost forgot this. We also need to have some strategic goal indicators, strategic objective level indicators that speak to the work we do as civil society, not just process indicators. So when we bring all of this together, I'm sure that our impact will be felt even beyond donor funding. And John, I will have some thoughts I will share with you after this. Global Fund money is going down. What do we do as civil society working together to bring in further funds, even after some countries have transited out of Global Fund? We need to think, and I think there are opportunities for us, but we need to work together. Let's talk of that outside of this because our time is short. Thank you. I'm stopping here.
Yes, I agree with you. And actually, you've transitioned us to the next discussion. And I think as we are talking about funds are uh, reducing, the also issue of sustainability. How do we sustain the impact of the grants, HIV, TB, malaria, and services that we've done to date? How do we sustain? And again, the question is integration the missing link? Is integration the silver bullet for sustaining the gains? So these are some of the discussion we have. And Brother Ayo, I will reach out to you. We can continue this discussion. And I'd like now to transition us into the next discussion. I think my colleague Lisa will take us through that discussion. I'd like to pass over the mic to you, Lisa.
Yes, thank you so much, John. That was a really interesting discussion, and we have been able to listen to our colleagues who are, providing us with policy perspectives as well as pragmatic shifts on how integration is being framed within Anglophone Africa as a region, as well as global levels. And this particular session that we are entering into is more of a community reflection session whereby we get to listen to how our communities experiencing integration for those communities that already are implementing at their different national levels. And then in Swahili we always say kwa ground kuko aje, which basically means like what is really happening at community level, what is really happening at the ground level when it comes to integration, because integration is not only a systemic reform that communities are getting to experience, but also it shapes how people are accessing services, how people are being treated, and what is being met in terms of community needs and what is being overlooked. Hence, the reason why this coming panel is really, really key, and it's important for us to listen and reflect. And most importantly, we are going to be looking at how is integration affecting key vulnerable communities within HIV, TB, and malaria. What are some of the ongoing interventions and responses within these three disease areas? And then what are some of the benefits, but also unintended consequences that people are facing when it comes to integration? And with me, I have a really amazing panel that is going to help us reflect on some of the key issues that communities are experiencing, but also key opportunities that we can look into, because integration is here for us to stay. And, people are saying integration is the overall sustainability plan when it comes to HIV, TB, and malaria services across board. So let us dive into this amazing session. And our first question is, going to be around what opportunities does integration within HIV, TB, and malaria services present when it comes to improving access, efficiency, as well as continuity of care within our different country contexts, but also within primary healthcare. And I'm going to invite our colleagues from Stop TB Partnership, we have James Mala to be able to share with us briefly what are some of the opportunities within the TB sector. And then I will also be inviting Mr. Ayo once again, just to share with us around the malaria sector, but also Cedric to come back on board and tell us briefly what are some of the opportunities that maybe we are not looking at when it comes to integration within the HIV sector. So quickly, let me hand it over to Ayo. I know you recently spoke, so just like in 5 minutes, let us know what are some of the key opportunities that you were alluding to. And then we can move on to Mr. James Mala and then Cedric once again.
Lisa, you might,
Ayo,
Lisa,
are
you
you
might
still
want,
with us?
Lisa, you might want to move to the next person because I think Ayo has dropped off.
All right. Can we hear from Mr. James Mala from Stop TB Partnership?
Thanks so much, Lisa. Thank you, colleagues at ENASO, for putting together this webinar. I am, I guess coming in later in the piece to this discussion, I think that there was a great deal of really insightful comments. I heard the more recent presentation around TB, and I think that in some ways that goes to the answers of the questions that you've raised. But I will use the opportunity, I think, just to flag a few things. I think from the outset, when we're talking about opportunities, but also potential concerns, it's really important that when we speak to integration, we have a clear definition of what we want it to be, or what we want it to mean, what we want it to include. Everyone is defining it differently. And it is really important that there is that shared understanding, particularly for TB communities, along with other TB stakeholders, about what that means, or what is trying to be achieved through those efforts of integration. Now, the second thing, I guess, linked to that for TB is it certainly is something where we need to make sure that it makes sense both on paper but also in practice. And I think that there were, again, in the previous TB presentation, some really good examples of how this can make sense in practice. But I suppose the risk here or the concern is certainly where something looks good on paper and pushing integration for integration's sake, which can present risks to the things in the program that are really working well, things that are unique to certain disease responses, which are important to recognize and as unique and to protect as such and to continue to invest in as such. And I guess for TB, one of the things we can certainly look at in this space is around DRTB. And drug-resistant TB and the need to make sure that you have that expertise, that nuance, that specialization, which maybe means that we can't just have that comprehensive integration for all parts, but for some we certainly can. Now, I think as well, one of the things for TB, particularly from the side of TB communities, is that there are elements of the TB response from communities which are emerging. And as we move to integrate, we need to also make sure that we are protecting those things that are important, even if they are in their infancy, making sure that they don't drop off. So it's also about how do we go about integrating sort of community-led initiatives while protecting those emerging TB survivor, TB community movements that are underpinning these and have the potential to continue to have really significant impact on the ground to end TB, but also in this context of integration and also may potentially beyond the 3 diseases to have an impact for broader health, for airborne related health issues, for pandemic preparedness, pandemic response, a range of things in that respect as well. So some further opportunities. In TB, one of the exciting things that's coming up is certainly around diagnostics. As we head into grant cycle 8, we really hope to see the increased uptake, increased investment in some of the newer diagnostic areas. There's in terms of some of the global fund guidance, Stop TB has some guidance, other partners have guidance on the particulars of these. But just to make a very short pitch on these, that we have near point of care diagnostics. We have new innovations around pooling of samples for testing. We have things like MPOC, which all present us with opportunities in diagnostics which are impactful, that they're effective, but they're also in terms of results, but they're also effective in terms of costs. So this is something where maybe there's a potential to increase the opportunity to integrate TB diagnostics in a greater level of primary healthcare, and also to where there are opportunities to take those services to where people are. Second, is certainly we know, we're heading towards a UN high-level meeting on HIV, and TB continues to be the greatest killer of people living with HIV. TB prevention among people living with HIV has to be a critical focus of scale up in terms of this integration agenda. It's something where there has been some promising results in some countries, but there's significantly further opportunity to use this as an opportunity to take forward. A third thing that I think is important here is around community-led monitoring. From the TB side, there is, a platform called One Impact. It is it has several 100,000 active users. It's across 35 countries, and it's already in several countries working not just on TB or DRTB, but also on HIV, on sexual and reproductive health, on some of the vector-borne diseases, malaria, but also, say, dengue. And so there are platforms such as this which can present us with a wonderful opportunity to integrate through a platform, but also to then disaggregate the relevant data, the relevant CLM, particular to the areas of interest or the priorities that we work on. So that's something which I think presents a wonderful opportunity around integration. I think that the final one that I'll speak to, noting, I think that we're a little bit behind schedule here, so I don't want to take up too much time. But this question of the barriers to access, there is certainly an opportunity for increased integration here. Recognizing things like stigma, discrimination are barriers to health across the three diseases. They manifest in different ways, but we can be smarter in how we're working together to recognize these and take them forward. Now, one of the things that's critically important to do that is to ensure that we do have continued investment in the communities who drive these efforts, whether it's key populations, whether it's TB survivor networks, whether it's groups of people affected by malaria. There is a need to maintain that base of knowledge, that base of expertise, that base of lived experience. It's very much the principle upon which a lot of global public health efforts were built. And I think that we need to be sure that as we take steps towards integration, we're also making sure that that integration is fully informed by that lived experience, and that those voices across the various key population groups, across the various health intervention areas, whether it be HIV, TB, malaria, or something else, are at the table and have the investments and the capacity to meaningfully contribute to very much ensure that anything that we're doing around integration is for the betterment of the disease responses that we currently have. When we integrate, it should be making TB responses more effective. When we integrate, it should be making TB responses cheaper. When we integrate, it should be making the things that work in TB better. So this is something which I think it's crucial to have these sorts of principles at our heart going forward. With that in mind, the governance arrangements around health and then the Global Fund at country level are of critical importance. Yesterday, Stop TB launched a report looking at levels of representation and impact on country coordinating mechanisms across 30 countries. The findings are not necessarily anything that's new, but it does provide that additional evidence which demonstrates that there are an underrepresentation of TB stakeholders on CCMs. That's particularly the case with groups of TB survivors and TB underserved populations. That there's an underinvestment in those communities themselves to be able to inform meaningful participation. And as a result, the levels of impact and the degree to which those priorities are supported at the country level also become a challenge. So, linked to integration, we need to make sure that that the communities of people affected by TB, irrespective of the diseases, have the support, have the capacity, but also are represented and able to participate meaningfully and in an equitable manner to help shape these discussions at country level. So with that, I might conclude. I will say again, thank you to Ianaso. From Stop TB side, we will have some further guidance coming out around GC8 and TB priorities. And we also have a series of webinars being done together with our friends at TB People and Georgetown's Center for Global Health, looking at how to strengthen TB and TB priorities across GC8, which we hope others will be able to join as well. So thank you very much. Back to you, Lisa.
Thank you so much, James. And thank you for like really pushing us forward. And I really appreciate some of the information that you have shared with us. And I believe that the communities on call are listening and really taking notes. And we look forward to the guidance from Stop TB Partnership that is really going to guide communities working towards TB response in the Anglophone Africa region. Please allow me to just shoot back the question to Cedric from GNP Plus around what are some of the opportunities. I know you mentioned briefly in your presentation, but maybe right now we can like really have a deep dive on what are some of the opportunities around integrating HIV. We have had a couple of complaints from HIV communities, but we know that, with sustainability and transition really being the key focus, communities can be able to view this from a different lens. So over to you, Jim. Cedric.
Yeah, thanks, Lisa. I think briefly, as I mentioned from the study, but also on the minimum requirement, but also from the case study in the 9 countries. I think I can group the opportunities in 3 main group, but I would say there's an if the integration of HIV is well done, meaning it's context driven, comprehensive enough to take into consideration the diversity of the people living with HIV, and it provides the package that is personal centered and also stigma free. I think the first opportunity that we can see is what we used to call the one-stop center, one-stop center, a one-shop center, in terms of you go to the health facility and you're not only going for your HIV treatment collection, but in given case you can also do for other NCD related, so meaning that the treatment can go from one disease to different disease, and diagnostic and management of different disease for one person. So it's easier if there's an opportunity for a person living HIV to collect their treatment, but at the same time do being taken care of at the same place. We know in many places when there's HIV clinic, it's not always that people with diabetes or hypertension, they can always receive the same care, the same HIV clinic. So it's not often like that. So when there's integration, we think that could be an opportunity to have a person-centered care in one place, and then avoiding the cost into transport, but also in time for people living with HIV who are seeking for services. I think that is the opportunity we see for HIV integration, and I think also James was mentioning that the co-infection could be much more dealt with when HIV is better integrated into primary health care. So that's one thing, and the second thing, which I think could be on another level in terms of what we have been doing as communities, what we know to do better, the outreach, like taking the experience of HIV response in terms of outreach. You can take it also advocacy, outreach, reaching those that are hard to reach, but the most vulnerable. These are the kind of experience that we could bring into within the integration of HIV into primary healthcare process. I know it's already there. Government, they have their community health workers who also does the outreach, but the experience of HIV could be another added value into the community health system strengthening because of the wide experience we have. The third element, which I believe could go more on the government level, which we can all benefit from, is the even if you take the example of last year in many countries, we've had some data being lost because of the system were not entirely run by the country or the government, and then some clinic could not really find out who is who just because the system was hosted somewhere else. So having the response on the HIV into fully integrated into the country response would actually maximize on the country system, health system strengthening, giving the opportunities for the country to use the funding to support their health system, but also, for the people who are receiving care and services from the country facilities benefit from that. It's a cost effective, of course, should the funding still available, but also if the funding on sustainability lens are not there, we believe that we don't want to come to a point where a country is looking for funding and then there's no, we do integration while there's no funding. So integration should be start the moment at least there's little that's now that the global fund is doing GCA, at least the transition and have a sustainability lens. And the country can take ownership of the whole response with and use the funding in a way that responds to country needs. I see those three opportunities, and I can also emphasize on the fourth one, which I believe that, as I say, there's a condition in terms of seeing these opportunities taking place is if the integration is done in the most effective way, is to see that in some cases you don't need to go, some people don't need to be openly living with the HIV. They can be living with HIV, but they don't need to be recognized as going to any given clinic because it's an HIV clinic. So that is a stigma related issue. There's a downside of that if the health workers are not trained enough. But we believe this, that's why I was saying if the integration is well done, the health workers are trained, and the stigma and discrimination is much more less, and people can access the healthcare facility without necessarily thinking this is an HIV clinic, but it's just a primary health care clinic, and then they can receive any services. If the health facility, health providers are well trained, then there's no issue of stigma and discrimination. I will stop there, and I apologize to maybe leave now. Thanks.
Thank you so much, Cedric. That was really, really comprehensive. And I like the fact that you aligned some of your responses to what James was speaking on when it comes to co-infection and how we can be able to integrate across all the three disease areas. So we really appreciate that. In the interest of time, integration is such a hot topic, guys. And I recognize that, time is moving so fast just when the conversation is really getting juicy. But please allow me to just quickly shift it and request that we briefly discuss around how integration is affecting our key and vulnerable communities. And I will just quickly invite Anil as well as Masopa, so that they can briefly give us the perspective on what are some of the key risks that integration poses when it comes to our key and vulnerable populations, specifically adolescents and young people in their diversities, as well as key and vulnerable populations. What are some of the key risks? But even as you reflect on the risks, how can countries as they implement integration, how can they be able to uphold human rights, which basically is centered around non-discrimination, confidentiality, and ensuring that services are equitable across board? So let me quickly just shoot that question to Anil to tell us more about it, and then Masopa. Thank you so much.
Thank you so much, Lisa. So firstly, I think in terms of the risks, the risk is unless we have integration that's co-designed with communities, we have a very real risk that the communities who are most at risk of HIV, TB, and malaria are going to lose access to services. And also, if integration isn't informed by implementation science, at best, we risk wasting very scarce resources on ineffective programming. And at worst, we risk rolling back the gains we've already made and having resurgence of disease. So basically, what do we need? We need evidence-based programming. And we need to ensure that we continue funding for community-led responses, which we know are highly effective in reaching marginalized communities, and who have also been leaders in service integration. So I think a lot of this depends on what we're talking about when we say integration. Are we talking about integration of services in terms of ensuring that, for example, if someone is diagnosed with TB, they're also connected to HIV testing and vice versa? Are we looking at integration? And this is something where community-led services have been highly effective, of integrating, for example, HIV care with broader sexual and reproductive health services, and then also mental health services. Or are we looking at integration at a systems level, where we're saying we're going to have a primary healthcare system that can provide a range of different services, included differentiated services, community-led services that are funded through the primary healthcare system, but are still implemented by the community organizations who have the reach into hard-to-reach communities? Or are we looking at integration as meaning that everything gets integrated into primary healthcare clinics, and that also you have a one-size-fits-all service that's provided through primary healthcare clinics? Unfortunately, a lot of the discussion in a lot of countries seems to be veering towards the one-size-fits-all approach in primary healthcare clinics. And if that is the case, what we need to understand is that all the people who at the moment do not have access to primary healthcare clinics, to state primary healthcare clinics, are going to lose access to services. And this, for example, criminalized communities in countries where you have the criminalization of particular communities, and those community members face high levels of stigma and discrimination that are barriers to accessing services in government health clinics. For example, undocumented migrants. For example, people who are undocumented workers in countries who do not have access to state clinics. All those people will lose access to care if we have a one-size-fits-all approach in state healthcare clinics. So we really need to ensure that the integration that we're designing is based on, first of all, actual community needs, and secondly, on implementation science. And we need to be realistic about this. There are some countries where elements of integration are already happening and where it's entirely feasible to integrate into the primary healthcare services. We have other countries where the current primary healthcare services are very, very weak, and where there are also major structural barriers to access. And in these countries, it's not advisable or feasible to start an integration process. You need to first start looking at how you are able to address the weaknesses within those services and address the structural barriers, because otherwise all we're going to do is, instead of integration strengthening our health services, we're going to weaken some services that are working at the moment. And just to end with emphasizing what Maureen said right at the beginning, this can't be a top-down approach. We need to ensure that the communities who are going to be receiving these services are involved in co-designing the integration solutions to make sure that we've got integration that works for communities. Thank you so much.
Amazing, Anil, and thank you for sharing your perspective with us. Let us just quickly, in the interest of time, move on to Masofa to share with us about the perspective from young people.
Hi Lisa, thank you so much. I'm gonna quickly also close my camera if that's okay. I just wanted you to see me. I stay in the most cold Africa, in the most coldest country in Africa, so it's really hot today. I would like to just quickly talk about the risks for key and vulnerable populations from a young person's perspective as the Have Voice Fund ambassador to Lesotho. Integration without intentional safeguards can reproduce the very inequities we are trying to dismantle. And I think one of the biggest risks is the erosion of safe spaces that have been built over years and years of community-led and key population-focused programs. For example, adolescent girls and young women often rely on discreet and youth-friendly HIV services. And if those are absorbed into generalized care without attention to privacy, we risk involuntary disclosure, and we risk stigma as well, and disengagement from care. I think similarly, key populations may avoid integrated facilities if they perceive them as less safe or more judgmental. There's also a structural risk that we often just, I don't know, we tend to really not talk about it a lot. Integration can sometimes become a cross-cutting exercise. This is where resources are consolidated but not reinvested equitably. And this can dilute specialized expertise and weaken targeted outreach and ultimately widen gaps for those already left behind. And to ensure that we go from integration to work, it must be anchored, like you said, in human rights framework from design to delivery. And this is how countries can institutionalize that. I think confidentiality protocols are very important that are actively monitored, not assumed, and anti-discrimination policies that are backed by accountability systems and community-led monitoring, where those access and services can report lived experiences in real time, which is very important to monitor and to really evaluate on whether there's progress in terms of integration. But most importantly, integration must just shift power. Communities, especially young people, especially women, especially key populations, must move from being consulted to being co-creators and decision makers. Every single time we feel like as young people, we're just a tick on the box, like, okay, there was a presence of young people in this training, there was a presence of young people in this particular exercise. So the minute we shift from being consulted to being co-creators, to being decision makers, to being present in decision-making conversations, so that there's also inclusivity and we feel included as well, and we feel that we are not left behind in conversations or in issues that may have an impact on us. Because without that, integration risks becoming technically sound, but socially disconnected. Yes, thank you, Lisa.
Thank you so much, Masupu, for that. And yes, you are very right that we do not need communities to be consulted, but we need communities to be included. So just allow me, in the interest of time, and I hope our colleagues can be able to hold on just for like 15 more minutes. Allow us to quickly just go into Kenya's community case study, where Kenya recently hosted the first integration summit within the region. And allow me to just quickly bring on board Solo from the Kenya KP Consortium to just give us quick reflections on some of the lessons learned. What were some of the key conversations? How did communities strategize around integration? And maybe it can provide us with an opportunity for communities in the region to be able to learn and strategize better when it comes to integration. So, Lo, the mic is yours.
Thank you very much, Lisa and all colleagues. I hope I am audible.
Yes, you are.
Perfect. I will only share 2 slides as I continue talking. Let me put it on slideshow. Is it on slideshow yet?
On my end, it is. You can proceed.
Okay, perfect. Perfect. So I will explain why the 2 slides. So just by history, so by history, you'll get that for the Integration Summit, this was now the second one. And then because the first one did not have many communities, and that was a learning. So with this second one, it was more diverse. I believe that's why now it got more visibility. And of course, it had a lot of other countries being included in terms of how we engage in matters integration. So going back to now what was there, looking at the agenda, us as key populations in all our diversities, we got engaged at the final planning sessions. You'll get that we had to fight so that we could actually be at the table of the Integration Summit in terms of our engagement at that level. So finally, we saw 4 of our colleagues actually get into the planning committee, but it was at the last stages of the program development. We had slots for key populations and other communities as well, because we had PLHIV, we had AYP, we had vulnerable populations and other communities in there. So I can say that as we discuss this integration conversation, communities need to be at the center. It is not just only the government conversation, it is a joint government and community conversation during this moment. We saw that at that time there were various themes when it comes to the integration conversation. Presently, we are looking at how best we have choice when it comes to the PrEP conversations. We have the PV ring, we have Kabele, we have LEN, and other preventive products in the market. So we did look at it from a point of how can us as communities actually be the ones actually now saying this is what we need when it comes to choice. And for me, looking at the larger integration framework, this needs to be included because there is no one definition for the integration definition. Integration requires to be responsive, integration requires to be very diverse, and all countries will actually need to come up with their own definition of integration. That is also what we got from that meeting. Going on and moving on ahead, looking at the launch of the various publications at the summit, we can say that governments are indeed doing their best in terms of documenting and ensuring that the HIV, TB, malaria, and more so the entire cascade of diseases are actually documented. And we got to launch, I believe, 21 documents that were actually speaking to various programs. And we saw that us as communities, we got involved in some of the documents. And for me, that launch signified a really good beginning, come that conversation of where is the voice of communities when it comes to the implementation of those documents. Moving forward, we know we are at the entire, I can say at the start or at the verge of continued conversations on GC8. Different countries are having different government to government conversations. So the G2G conversations and the GC8 conversations, they are mirroring each other, whereby governments are talking about integration. So Us as key populations from Kenya, we did come up with how best does integration actually get done and the various models of integration. This we have actually proposed to the National AIDS and STI Control Program, where the KP program is actually embedded. So we are in the process of ensuring that our voice actually leads into that space and ensuring that the definition of integration is as diverse as possible, and it will actually get into the GC8 conversations and the G2G conversations. We all know what's going on under the G2G. It's in heavy secrecy when it comes to, who is there, what are the decisions, and where are we at? As communities, we've been left out, but we are appealing to all governments to actually include, communities, because the response relies with communities because it is us. And that's why I put the first slide over here. These are some of the lessons for primary healthcare on integration that we actually did, or that we found out when we did a survey as the key populations transnational collaboration. We are looking at the community. Community needs to have trust when it comes to the foundation of integration, because we are at the center of the response. We need to continue looking at safe spaces, because right now in Kenya, you can actually see the drop in reach when it comes to the key populations programming because of integration. We all know that because of the stop work orders, many peer educators and outreach workers actually went home. This has affected the counties whereby the peer educators went and the outreach workers went. There is that conversation of on the role of peer educators. So it is actually been seen that we need to go back to our standard model and ensuring our safe spaces are there. Most of the counties right now are reporting zero. So where are our communities right now? We need to be there to ensure that our spaces that offer value added services are actually maintained. Looking at integration is not just a one-stop process. It is actually a sequence of heavy discussions and heavy processes. So we need to continue ensuring that integration is not just one stop. We need to ensure that the transition into integration is well done. Looking at hybrid models, of course, this is something that we need to ensure that even communities that are in the very far off rural areas are actually reached by service delivery. Looking at workforce, we saw how the workforce was affected by stop work orders. We need to discuss what is the government doing when it comes to support of the workforce. CLM, this is community-led monitoring. This is where the voices of our feedback to health service provision is at. We need to have a place and a voice, excuse me, when it comes to CLM. Data, we know that countries have actually refused the USG conversations because of data rights and data infringements. What are we doing, especially when it comes to the countries that have accepted, the frameworks and the USG conversations when it comes to issues of integration? And then looking at the legality of criminalized populations, we know that many populations are criminalized, most so the key populations. So we need to start thinking about decrim. And then I want to just also flash this slide that we want community programs that are very flexible, that are responsive to our strategies, and we are there as key populations to offer the strategies, meaningful engagement and involvement. And this is the time that when we are going for GC8, there will be the definitions of integration. There will be the definitions of who is community and who is government. We need to be at the center of the conversations come GC8. Diversity when it comes to offering solutions, we need to ensure that all populations, all communities are recognized. looking at various challenges and experiences because the response relies on us. Looking at realistic solutions because other speakers have also showcased the fact that we are living in resource constrained period. What does this mean as we continue looking at the HIV response? Looking at sustainable practices, sustainability is, the buzzword in all boardrooms, in all conversations. And I believe sustainability needs to be realistic as well. How best do we actually branch moving forward? And so my take home as I actually wind up, it's that we need to ensure that we have working country definitions on integration and communities to be at the center of the conversations. We need to ensure that we follow on the government to government conversations and where we are at if we get that information. And then lastly, looking at when we are actually doing the GC8 country proposals, how best do we place ourselves as communities because the response relies on us. This conversation is still ongoing, and we hope that all people are actually in these conversations as communities. Thank you very much, Lisa. Over to you.
Amazing. Thank you so much, Solo, for sharing that case study. And I think that's an opportunity for, the region to really, really learn and get to be able to reflect on some of the key ways that they can be able to integrate integration within the different country context. But what I really appreciate is something that you have said, that integration must not come at the cost of equity, rights, or choice and power for communities. And I really want to appreciate that case study. And I hope that, colleagues from the different Anglophone regions can be able to reach out to you to get what you've just presented. So as we are winding up, we do have an upcoming study or survey that is being conducted by the Global Advocacy for the Data Hub when it comes to integration, CCM governance, and all these amazing experiences by communities as they are getting to write their funding requests for GC8. So allow me to just quickly in the next 5 minutes invite Alana Sharp to quickly speak to us about the Msingi study, which has a big role when it comes to integration and how communities can be able to align and center themselves around this. Alana, over to you.
Thank you, Lisa. I'll speak very quickly because we're just at the end, but I just wanted to tell everyone that this is a study that will be coming soon, and it builds on the RISE study we did some time back about community engagement with CCMs. And so we're trying to ask the question about how is Global Fund integration and transition affecting community-led programs, services, and advocacy. And we will be asking what are the barriers to and facilitators of successful health program integration and transition using real-world evidence. And then the last thing is we're going to be looking at what governance and advocacy spaces exist outside of the CCM where communities can continue to influence health programs. For example, as more and more power and ownership of health programs shifts to ministries of health and away from the CCM itself. And we're not launching yet, but I did want to share it in case anyone is very interested. If you'd like to be able to participate and share your own experiences, you can just sign up with us at the Global Advocacy Data Hub, and then you will receive the information about how to participate when we go live. And if you're very interested in talking more about this project, you can always reach out to me as well. So I'll share that information in the chat. That's all. Thank you.
Thank you so much, Alana, for that. And I'm sure that all the amazing stakeholders on this call will be available to collaborate and be able to provide community perspectives when it comes to the study. So for me, as we close off, I just want to thank all of our speakers, our amazing partners, and participants for contributing to this amazing and rich conversation, which is not only necessary and timely, but it's a conversation that keeps on going. We can really not speak about integration because, communities are really interested in it and they keep shaping their strategies around it. And this conversation does not end here today, but it must continue in our different countries, within our different processes, including the GCH funding requests that are currently ongoing. And we must be able to continuously shape decisions at our different policy levels and country levels. So I just really want to appreciate all of you, and quickly hand it back to my colleague John to just give us a quick summary of the key highlights that have come up from this conversation and close the meeting for us. Back to you, John.
Thank you. Many thanks, Liz, and thank you so much, everyone, for taking time to participate in this call. Some of the things that are coming up is that we need to understand that integration for it to work, for it to be successful, like any other health program policy implemented, we need communities to be at the forefront. And we've heard from most of the speakers that not just to be consulted, but to co-create the path that we want to take in and around integration. And the other thing that we have seen, and this I think we have agreed, is that if not done properly and well done, I think integration can have can take us back, and we can lose the gains that we have managed to get after a long time of addressing the 3 epidemics. So we need to do it properly in a way that it protects human rights, protect access to health services, and also ensure safe spaces are protected. And we also understand that we also heard that integration is also not one size fits all. Each context has its own unique ways of addressing some of these things, and we expect communities and countries to have unique ways of integration. And we also need to also realize that we understand we are also coming from the perspective of limited resources, and integration is one of the strategies that can help maximize the little money that we have to achieve the same or better impact in our programming, and also a strategic approach in sustaining the services. And most important, integration can work if we continue building community systems. I think we've heard that from a number of speakers. The systems that we have need to be strengthened. Community interventions need to be strengthened for integration to be able to work, and also give the results that we have. So these are some of the things that have come up. And we really want to thank once again everyone for participating. Thank you, our partners, people collaborated in making this happen, and also thank you for the community members who have spared some time to get on board and participate. We will continue. Normally, we pack all this that have come up. We've picked your comments, your questions. We'll pack them and also reflect them in our newsletters that we normally have, the periodic newsletters, and we'll have newsletter on integration to support this discussion and ensure we have all these questions that have been asked, the responses, and also the information that we receive from communities as we engage. Otherwise, I'd like to say thank you so much, and we apologize for taking too long in this meeting, and we promise to improve and strengthen our time management for future meetings. Otherwise, I'd like to wish all of you a good afternoon and good evening. Thank you, and enjoy your evening.
Thank you so much.
Thank you. Bye-bye.
Bye. Bye.
Take care, everyone. Bye.